Hello and welcome to Derm School. Today, we will take a look at connective tissue diseases. We will be covering 3 conditions today: lupus erythematosus, dermatomyositis, as well as scleroderma. Our first topic is lupus erythematosus. When we think about lupus, we need to refer to the abbreviated Gilliam classification. So in this classification, cutaneous manifestations can be divided into 2. LE-specific skin disease, namely cutaneous LE or CLE, as well as non-specific skin disease. We first look at LE-specific skin disease. This is further divided into 3 categories: acute cutaneous lupus erythematosus or ACLE, subacute cutaneous LE or SCLE, and lastly, chronic cutaneous LE or CCLE. Examples of ACLE are localized ACLE, also known as a malar rash or a butterfly rash. You can also develop generalized ACLE, also known as maculopapular lupus rash, malar rash, or photosensitive lupus dermatitis. Next, under SCLE, there are 2 types: annular SCLE or papulosquamous SCLE. The latter condition is also known as disseminated DLE, subacute disseminated LE, as well as maculopapular photosensitive LE. Under chronic cutaneous lupus, you have the classic discoid LE or DLE. This can be localized or generalized. Next, you can also have hypertrophic or verrucous DLE, lupus profundus, mucosal DLE, whether oral or conjunctival, lupus tumidus, also known as urticaria plaque of LE, Chilblains LE, as well as lichenoid DLE, which is an LE lichen planus overlap. LE non-specific skin disease include necrotizing and urticarial vasculitis, livido reticularis, Raynaud phenomenon, dermatomyositis, as well as bullous lesions in LE. This is the 2019 EULAR-ACR classification criteria for SLE. The entry criterion is an ANA, which is positive, namely 1 in 80 or above. If this is absent, do not classify as SLE. If present, apply additive criteria. So SLE classification requires at least 1 clinical criterion and 10 points and above. Within each domain, only the highest weighted criterion is counted towards the total score. So there is divided into clinical domains and immunology domains. Clinical domains include constitutional, hematologic, neuropsychiatric, mucocutaneous, serosal, musculoskeletal, as well as renal. And you can see that the details are illustrated in the table. Immunology domains are antiphospholipid antibodies, complement proteins, as well as SLE-specific antibodies. We first look at ACLE. Now, this is the typical butterfly rash that we all know about. It can be described as an erythematous, confluent, macular butterfly eruption on the face, which is sharply defined. Patients may have fine scaling, erosions, and crusts. If the ACLE is generalized, patients can present with erythematous, discrete papular or urticarial lesions. Sites include the face, dorsal of the hands, arms, as well as the V of the neck. We now move on to subacute cutaneous lupus erythematosus, SCLE. This affects 10% of the LE population, and 50% of these patients have SLE. It is more common in young and middle-aged patients, females more than males. Precipitating factor is often sunlight exposure. It is usually sudden in onset and associated with mild fatigue, malaise, arthralgia, and fever. Patients usually have some criteria of SLE, such as photosensitivity, arthralgia, serositis, and renal disease. Patients can also have the presence of anti-Ro and anti-La autoantibodies. These are the clinical manifestations of SCLE. The first type is the psoriasiform papulosquamous type, in which it is sharply defined with slight delicate scaling and involves into bright red confluent plaques. The shapes are often oval or aciform or polycyclic. Next, you have the annular type, and these are bright red annular lesions with central regression and little scaling. In both types, you may have telangiectasia, and they resolve with slight atrophy and hypopigmentation. Patients may also have periangular telangiectasia and diffuse non-scarring alopecia. Distribution of SCLE is typically over light-exposed areas such as the shoulders, extensors of arms, dorsum of hands, upper back, as well as the V-neck area of the upper chest. Management of SCLE can be divided into topical, using glucocorticoids, pimecrolimus or tacrolimus, or systemic, such as thalidomide, hydroxychloroquine, quinacrine, prednisolone, and immunosuppressants if patients have systemic involvement. We now move on to the last category, which is chronic CLE, CCLE. And this is usually seen in patients aged 20 to 45 years, females more than males. Most cases only have cutaneous LE, and there is a lesser role of sunlight. Duration ranges from months to years, and patients may have mucous membrane or nail involvement. Chronic discoid LE usually presents as bright red papules evolving into plaques. These can be round, oval, annular, or polycyclic. Lesions are usually sharply marginated with adherent scaling and irregular borders. It often expands in the periphery and regresses in the center to have atrophy and scarring. In burnt out discoid LE, patients have pink or white macules and scars, and it can be hyperpigmented in brown or black skin. Apologies for the typo, it's black with a K. This is a picture of chronic discoid LE on the cheek on the left, and very, very typical is DLE in your conker bowl, which is also known as Schuster sign. Chronic discoid LE can be localized or generalized. Sites include face, scalp, dorsal of forearms, hands, fingers, toes, and less frequently on the trunk. Management of discoid LE includes local glucocorticoids and calcineurin inhibitors, as well as including intralesional triamcinolone for small lesions, the use of antimalarials such as hydroxychloroquine or quinacrine, systemic acitretin, as well as thalidomide. For chronic lupus panniculitis, these are firm, circumscribed, subcutaneous nodules or plate-like infiltrations of the skin. Patients may also have CDLE, and about 35% have mild SLE. It is also characterized by subcutaneous atrophy and scarring, presenting as sunken areas. Sites include face, scalp, upper arms, trunk, thigh, and buttocks. Management is with antimalarials, thalidomide, and systemic corticosteroids. And this is a picture of chronic lupus panniculitis. Our second condition that we are looking at today is dermatomyositis. This is an idiopathic inflammatory myopathy. It can be juvenile or adult in onset. For patients aged more than 55 years old, it is usually associated with malignancy. It is a clinical spectrum which ranges from amyopathic dermatomyositis to polymyositis with only muscle inflammation. Symptoms are photosensitivity, muscle weakness, manifesting as difficulty in rising from a supine position, climbing stairs, raising arms over the head, as well as turning in bed. Next, patients can also complain of dysphagia or burning and pruritus of the scalp. These are the skin lesions of dermatomyositis, and typically we think about the periorbital heliotrope flush, and this is usually reddish purple and edematous. It may extend to the scalp with the presence of non-scarring alopecia, face, upper chest, and arms. These are Gottron papules. They are flat-topped violaceous papules with varying atrophy. Common sites are the nape of the neck, shoulders, knuckles, and interphalangeal joints. Periangular erythema may also occur. We are looking for telangiectasia, thrombosis of capillary loops, and infarctions. Other manifestations are stellate scarring on the elbows and knuckles, as well as calcinosis cutis. For muscle involvement, patients present with progressive muscle weakness affecting the proximal or limb girdle muscles. They can also have muscle tenderness or muscle atrophy. Occasionally, this can affect the facial or bulbar muscles, pharyngeal or esophageal muscles. Other organ involvements include interstitial pneumonitis, cardiomyopathy, and arthritis. In patients aged more than 50 years, look out for associated malignancy, particularly at the ovaries, breast, bronchopulmonary, GI tract, as well as nasopharyngeal carcinoma, especially in southern Chinese. Investigations. You have elevated creatine phosphokinase, aldolase, lactate dehydrogenase or LDH, and glutamic oxaloacetic transaminase. You also send for autoantibodies to 155 kilodalton N or SE kilodalton, Jo1, ANA, anti-Me2 in classic dermatomyositis, anti-TIF1, which is related to cancer risk or juvenile disease, anti-NXP2 in severe muscle disease and calcinosis, as well as anti-MDA5, which has progressive interstitial lung disease or amyopathic dermatomyositis. Patients may also have elevated 24-hour creatine excretion in the urine, and other tests include EMG, MRI, ECG, chest X-ray, skin and muscle biopsy, as well as malignancy screening. Management of dermatomyositis ranges from prednisolone, azathioprine, methotrexate, hydroxychloroquine, cyclophosphamide, cyclosporine, anti-TNF-alpha agent, IVIG, JAK inhibitors, as well as rituximab for myositis. Lastly, we take a look at scleroderma. This is a multi-system disorder in which there is inflammatory, vascular, and sclerotic changes of the skin and internal organs, such as the lungs, heart, and the GI tract. Limited systemic scleroderma, or LSSC, including CREST syndrome, accounts for 60%, versus the other type known as diffuse systemic scleroderma, or DSSC. Onset is usually 30 to 50 years old and affects females more than males. Symptoms include Raynaud phenomenon with digital pain and coldness, pain or stiffness of fingers and knees, migratory polyarthritis, heartburn, dysphagia, constipation, diarrhea, abdominal bloating, malabsorption, weight loss, exertional dyspnea, and dry cough. Skin over the hands and feet. For early changes, you see the presence of Raynaud phenomenon, in which there's pallor followed by cyanosis and lastly rubor. They can also have non-pitting edema, as well as painful ulcerations at the fingertips and knuckles, which heal with pitted scars. Later in the course of disease, there is sclerodactyly with tapering of fingers with waxy, shiny, and hardened skin. Patients can also have leathery crepitation over the joints, flexion contractures, periangular telangiectasia, claw-like nails, loss of distal phalanges, and loss of sweat glands and hair. On the face, there is usually periorbital edema in early scleroderma. For late changes, there is loss of normal facial lines, mask-like facies, thinning of the lips, microstomia, radial perioral furrowing, a beak-like sharp nose, telangiectasia, and diffuse hyperpigmentation. This is a picture illustrating sclerodactyly, microstomia, and telangiectasia. On the trunk in DSSC, early changes involve the chest, proximal upper and lower limbs. There is tense, stiff, and waxy appearing skin, with impairment of respiratory movement of the chest wall and impairment of joint mobility. Other changes include cutaneous calcification, color changes such as hyperpigmentation, while on the limbs, you can have perifollicular hypopigmentation. On the mucous membranes, patients can have sclerosis of the sublingual ligament, as well as painful induration of gums and tongue. Distribution in early LSSC, it affects the fingers, hands, and face. For late, you have involvement of the distal upper and lower limbs, as well as occasionally on the trunk. For DSSC, sclerosis of limbs and trunk may start soon after or be concomitant with acral involvement. We now take a look at an entity called Crest syndrome. This is characterized by calcinosis cutis over the bony prominences, fingertips, elbows, and trochanteric regions. Raynaud's phenomenon, esophageal dysfunction, sclerodactyly, as well as telangiectasia on the face, upper trunk, hands, and GI tract. On general examination, look out for the following features: esophagus, dysphagia, diminished peristalsis and reflux esophagitis, gastrointestinal, constipation, diarrhea, bloating, malabsorption. Lung, pulmonary fibrosis and alveolitis with reduced pulmonary function. Heart, cardiac conduction defects, heart failure and pericarditis. Kidney, uremia and malignant hypertension. And musculoskeletal, carpal tunnel syndrome or muscle weakness. Investigations include autoantibodies such as anti-nuclear antibodies for DSSC, anti-centromeric antibodies, DNA topoisomerase 1 or SCL70 antibodies, anti-RNA polymerase 3 in those with renal crisis and potent mortality, anti-PMSCL in patients with Raynaud's phenomenon, and foretells better prognosis. You can also perform skin biopsy. In terms of management, systemic glucocorticoids are used early in the disease for limited periods. Other treatment options include EDTA, aminocaproic acid, D-penicillamine, para-aminobenzoate, colchicine, cyclosporine, methotrexate, cyclophosphamide, mycophenolate mofetil, photophoresis, avoidance of cold exposure, as well as smoking cessation. Studies or trials have been conducted in which immunoablation or autologous stem cell transplantation has been tried, as well as targeted therapy against interleukin-6 receptors, interleukin-1, or TGF-beta. For prognosis, for DSSC, it is often slow, relentless progression, and 10-year survival is usually more than 50%. Causes of death include renal, cardiac, and pulmonary disease, and spontaneous remission may occur. Whereas for LSSC, it slowly progresses, it's more favorable, and patients may not have visceral involvement. So that's all on connective tissue diseases, and we'll see you next time on the next installment of Derm School. Have a great day.